Think forward. Think Research Channel.
So I thank everybody for coming. I always think it's a privilege to be able to talk in a public setting about something that I'm really, really interested in. I'm a clinical neuropsychologist situated in Stanford's Department of Neurology. And for those of you who do not know what a neuropsychologist is that I give different tests looking at someone's mental functioning or cognition. So what is cognition? Well, cognition is someone's attention span, their short-term memory, their memory for information that they hear or see. Okay? Spatial skills, so their sense of direction, how well they can put things together. Okay? Their language abilities, how well they express themselves, how well they comprehend what someone says to them, and also something I call executive functions, which is sort of what most people know of as multitasking, planning, organizing. Okay? And I sort of came into this field from a different area. I was originally in psychiatry, and I did a lot of psychotherapy, and looked at different psychiatric conditions such as schizophrenia, manic depression. And for some reason or another, I found myself going into neurology because I sort of had a lot of interest in neurological conditions as well. And psychiatry and neurology, there's great overlap in those two fields. And a lot of the illnesses that you hear can affect psychiatric and neurological aspects. And so it was so fascinating that I felt that it was something I wanted to pursue for the rest of my life. Now, we're here to talk about dementia, and dementia is really, I think, the thing that I feel so passionate about in understanding, in knowing, and in conveying that information to people who are struggling with it, who want to know more about it. I think it's a very difficult condition to understand. There's a lot of misconceptions about it. And today I'm hoping to sort of, as the brochure or advertisement states, try to dispel those misconceptions. Okay? And a lot of what I'll be talking about is based on patients that I see. So it's really my direct clinical experience from my at least somewhat short career so far. So when we talk about dementia, I think the first question that we need to understand is, well, what is the definition of dementia? A lot of times I sort of assume that that is readily apparent, but many times that's not the case. So dementia, as defined by certain clinical criteria, is the development of multiple cognitive deficits that include, most of the time, memory and at least one other cognitive skill area. Aphasia essentially means a language disturbance. Agnosia involves misperceiving of objects. So if you have a family member that does not recognize you or cannot recognize an object, that would be some form of agnosia. Apraxia is an inability to sort of perform commands or different kinds of movements. Okay? And executive functioning is what I mentioned a little bit before, planning, multitasking, organizing, okay? At any time, if something is not clear, please ask me questions. I'm more than happy to clarify some things. My goal in talks, I personally am not one of the most gung-ho people going to a talk myself. I feel like if I could learn one thing from a talk, I feel that I haven't wasted my time. So hopefully for those of you here, if you've taken something or will take something from here, if you can learn just one thing, I think that would be great. And so before I go further, I just, from my experience, I wanted to get a sense of, with the people in the room, this talk is meant for people sort of in the early stages of dementia and depression. And I'll try to sort of, adjust what I say to different stages of dementia, because I think sometimes what I say, may apply to earlier, dementia, but not necessarily later dementia. And so I just wanted to clarify that, okay? So that is the definition of dementia, okay? And dementia really involves cognition, your ability to think, to reason, and to remember. And, and another thing that I think it's important to clarify is that there are many different types of dementia. Many people have the assumption that Alzheimer's is the only form of dementia you can have, and that it's not true. It is the most common form of dementia, but there are many, many different types of dementia out there. So for example, you can have Parkinson's disease that leads to dementia. You can have something called frontotemporal dementia, where memory is not the main issue, but planning and organizing is the main issue. So, most of the time I'll try to sort of focus directly on Alzheimer's, but I want to make that point across that there are many different forms of dementia, Alzheimer's being the most common one, okay? All right. So, by and large, the literature really suggests that there are overall low levels of knowledge with respect to the prevalence, the causes, and symptoms of dementia. And in my experience, I found that not just with lay people, but also many times with professionals as well. What is dementia? And people sort of lumped, if you have memory trouble, you must have dementia. And that, of course, is not true. And so let's talk about the myths, related to these aspects here. So the prevalence of dementia, okay? So what are some common myths that people hold or that patients I've met have told me? Okay, so dementia only affects other people. It cannot happen to me or to people I know, okay? Dementia affects only the patient, not his or her family. I think for anybody who's a caregiver, that you would get chuckles to know how ridiculous that statement is. So that, of course, is not true. The reality is that uncertainty or confusion about what causes, dementia may provide someone, a rationale to deny that somebody has the illness because they don't belong in the at-risk group, okay? Now, there have been studies showing that there is a genetic basis for many different types of dementia, but just because your family doesn't have a member with dementia does not mean that it's something that you don't have to totally care about. Dementia can happen, despite the fact that your grandparents or your parents did not have that in their history, okay? 6 to 8% of people over age 65 have dementia, and 33% of those over age 85, have some dementia symptoms. So those percentages, to me, are pretty high. And I think this is something that's going to be more prevalent as our society gets older, and it's something that we really have to know how often it occurs, okay? So the causes of dementia. A lot of times I hear different viewpoints about what leads to it, okay? Personality, okay? So what kind of myths are related to personality? Well, people with dementia act in a certain way because of prior negative life experiences or childhood difficulties, okay? So something in their history or in their background led to, the present state. People with dementia can control their behavior, and they do things deliberately, okay? This is something that I hear quite often when I do evaluations. I would be talking to the spouse, and they would be saying that, oh, well, my husband, I know him, he's just doing this to sometimes get back at me. And a lot of times it's really enlightening to tell them that, it's not deliberate, and sometimes it's out of their control, okay? Failure to act properly is a result of laziness, stubbornness, resistance, or a lack of motivation. This is also something I hear a lot of, that if he only worked at remembering, well, then there wouldn't be any problems and life would be hunky-dory. So the reality of it is that illnesses such as dementia, which lack obvious physical signs, may lead people to misattribute somebody's behavior to poor effort, malevolent intent, personality traits, or prior life experiences, okay? Now, I'm not saying that those factors have no part in what somebody does, but certainly when you're talking about dementia, you're talking about a loss in ability and a loss in function. And many times, people are either unaware of what is going on, they may not remember that they're doing certain things. And I think it's important for any caregiver who's going through this, especially in the early stages, to understand that this is a normal part of a dementing process. And does it make the situation better? Perhaps not. But can it promote some level of empathy and compassion? Perhaps. And I think that's what would be helpful, a lot of times. If people assume behaviors are due to lack of morals, what will happen? Well, they may resort to reasoning with or re-educating the person. So you're under the impression, well, that my husband, if I reason with him, and if he understood why, he's doing these negative things, then life would be better. If it is dementia, many times that most likely will not work, especially as the person progresses in their dementia. Okay? So mental illness, learning disability. Okay? So what is a common myth here is that people with dementia may act in a certain way because of a mental health problem. I remember one person telling me that, well, they remind me of somebody who has schizophrenia, where they have bizarre thinking. And certainly, dementia and schizophrenia are two separate entities. They are not the same thing. People with dementia may act in a certain way due to a learning disability or mental retardation. I remember someone from a different cultural background who came in and told me that, well, this is something, earlier on in their lives that caused this to go on. He had dyslexia, and somehow I'm sure that's part of why he can't remember names or can't read. And so again, how often people come in and tell me this, it does happen. And I'm always, I guess part of me is always somewhat surprised when people hold certain views. And I think it's important for society to really understand that these are fallacies. These are not truths. Okay? People with dementia are not insane, going crazy, necessarily psychotic, which means hearing voices or seeing things, or learning disabled. Okay? So all of those labels do not apply when you're talking about dementia or Alzheimer's. Again, these are separate entities apart from dementia. Okay? So I'm hoping that a lot of these things, for those of you who don't know this, that now this is sort of knowledge. And for those of you who do know these things, they sort of confirm what you already know. So the symptoms of dementia. Okay, so what kind of beliefs do people hold regarding dementia? Well, physical symptoms. Okay, patients with dementia are usually drowsy. Okay, normally patients with dementia are quite alert and awake during the day. If you see drowsiness in a family member or someone close to you, that may signal a drug interaction, poor nutrition, depressed mood, or even sleep disturbance, okay? So there are many different factors that can account for drowsiness in someone, but those are probably the most common variables you should look at, okay? So if an elderly person is taking multiple medications, that can lead to drowsiness, confusion. If they're not eating enough or drinking enough, that also can result in drowsiness. And sleep disturbance. I don't know how many times I've asked people, and they talk to me about things like sleep apnea, or and how they just, how that can affect their ability to be alert during the day. So if you see, a loved one or someone close to you with drowsiness, you would want to evaluate the person's sleep pattern, the types of medications they're having, their mood, and their overall level of consciousness, okay? So these are important things to rule out, because when we talk about dementia, for the most part, drowsiness really does not apply, okay? All right. It is just a simple fall, okay? A lot of times when I interview patients, they tell me, oh, they've fallen, they fractured their hip. And I remember many times a family member would say, well, that's just, as when you get older, you have accidents, so that's just part of getting older, so don't make a big deal out of it. And the reality is that few elderly people are admitted to a hospital after a fall simply because they have slipped or tripped. To merely assume the explanation is a problem in the environment, such as poor lighting, for example, may indicate that certain conditions may be overlooked. So macular degeneration, so some problem with your eyes. Impaired visual perception, okay? That may be related to changes in your brain that's going on, okay? So, and a lot of times when I say this, I don't want the message to be that, well, if, grandmother or grandfather falls, then you need to start thinking about all of these things. But certainly, it may not just be a simple accident. There may be other things that are going on that's accounting for what you see in front of you, okay? All right. People with dementia may also exhibit more physical problems, such as poor balance, trouble walking, or slurred speech. Disabilities may not necessarily be due to an accident or alcohol intake. So again, when we talk about dementia, a lot of times you're talking about a cognitive component, but there's also physical changes that can accompany it. And for some types of dementias, the physical symptoms may be the first signs of a dementia, okay? So the most common one would be Parkinson's, where you would have a tremor, constant falling, incoordination, okay? So that may signal some sort of brain illness, okay? Behavioral symptoms. This is the area that I think most people have questions and concerns about, and typically because it's the most disrupting when you're dealing with dementia. You should expect violent behavior from someone with dementia, okay? So I've met many people who say that violence accompanies dementia. And the fact is that aggression, many times in the early stages of dementia, may occur because the person misunderstands or misperceives the actions of people around them, and they lash out because of feelings of fear, anger, or mistreatment. The person may also feel frustrated at being unable to do something he may be able to have done before. Agitation can also happen because of hunger, thirst, physical discomfort, poor lighting, unsafe surroundings. Okay, so a lot of times in the early stages of dementia, aggression is a reaction to something that's dissatisfying. Maybe the person didn't have enough to eat or enough to drink. And especially if communication is affected, this may be their best way of letting you know that something is wrong. Okay, and and so it's important to know in the early stages that aggression, is not initially meant to antagonize you or to get the better of you, but it may be a way of expression of needs that the person can't, convey to you in any other way, okay?
It may occur. How often does it occur?
Aggression? I think in the early stages when we're talking about Alzheimer's, okay, my experience has been it doesn't happen that much. Okay? I think when you get to the middle and later stages, then these behavioral symptoms occur much more. Okay? So when you get to the moderate and advanced stages of Alzheimer's, I think that's the point when you see this type of aggression and acting out. There are other different types of dementias where this is actually sometimes the predominant symptom. This is the first thing you see. And so those would be frontotemporal dementia, where behavioral changes is the first noticeable sign in someone's condition. But when we're talking about Alzheimer's, the first thing, by and large, is memory. That is the first thing you see, and everything else comes afterwards. Okay? All right? Okay. So the reality is that sudden aggression in someone who was never violent before may suggest maybe a medical condition, drug toxicity, an infection. An infection can be anything from like a urinary tract infection or just something which affects the entire body. Okay? So, and that's really consistent with what I know, that if somebody was calm and sort of mild-mannered all along, it's highly unlikely that suddenly they would react in such a different, violent way. It may be a medical cause, but it's really not something that is typically consistent with something like Alzheimer's. Okay? So one of the things people believe in is that using restraints and sedatives to calm someone agitated. Okay? So now I remember talking about this slide with someone, and someone had a family member in the advanced stages of Alzheimer's disease. And that person told me, well, in those advanced stages, this may be what you need to do to deal with agitation and aggression. And certainly I think, when we're talking about Alzheimer's or any dementia, you have to really talk about what stage it is. And in the advanced stages, this may, it's a different type of thing that we're talking about. But when we're talking about early stage dementia, restraints and sedatives may actually worsen a situation. One thing may be to reduce the amount of medicines the person's taking, asking somebody, a close family member, to help orient and reassure the person, or just really talking simply and slowly to calm the person down. Okay? And again, I really realize that this is an individual thing. It depends on what stage you're talking about. And certainly some people with Alzheimer's or some other dementia, the behavioral symptoms are quite severe, and you may not be able to do these things. But I always feel that in general, if you can do this and avert restraints or any sedatives, that's probably the better recourse. Okay? So generally, it is really difficult for caregivers to cope with behavioral symptoms like aggression, apathy, hallucinations, delusions. And many times, because my experience has been that it seems that those behavioral symptoms on some level may be more controllable. Well, grandfather can certainly control these things, he just doesn't want to. And naturally, these are the most disruptive things when you're a caregiver. How do you manage these types of things, especially aggression? Okay. The cognitive symptoms. Okay. Yes. Yes. So the comment was when sort of in the early stages and when someone recognizes that there are changes, when that person naturally be depressed. And I think that probably accounts for why depression and dementia a lot of times go hand in hand, especially in the beginning. I think the person realizes, wait a second, something is wrong. This is not how it's supposed to be, and I know this is not who I am, and it's a reaction to the changes that are going on socially and cognitively. And so I think that is the case. I mean, intuitively, you would think that that would accompany the early stages of dementia. Yes? And I think when we talk about dementia, denial is probably, when we talk about Alzheimer's, that really applies. And it's hard to say, is it denial? When someone has Alzheimer's, in the beginning, it may seem like, oh, they're not facing the changes that the rest of the family is seeing. And I think some of it is denial, but some of it is also lack of insight. Okay? And that's one of the predominant things that go with Alzheimer's is lack of insight. And what is insight? To take a step back and to recognize what is going on with yourself. Okay? And so I think that's probably one of the most disabling of the symptoms of Alzheimer's, to not be able to understand that this is happening while everybody else sees it, but you don't. Well, Alzheimer's is already a type of dementia, okay? So when you talk about Alzheimer's, you're already talking about dementia in general, okay? So when you think about dementia, you need to think of this big umbrella, okay? And that this umbrella covers many different conditions. And so, and Alzheimer's is a big part under that umbrella, but there are other things that is dementia as well. And as I mentioned, Parkinson's disease can lead to dementia. Frontotemporal dementia is another type of, dementing illness. And so, and sometimes you can have an infection in your body that can lead you to have, another type of dementia. So, when we talk about Alzheimer's, Alzheimer's is dementia, okay? But not all dementia is Alzheimer's. So that's what you need to know, okay? Yes, ma'am. I think, when we think about senility, we think about normal age-related change. Okay, so things that would normally go with regular aging. So dementia is not normal aging. You could think about it as a rapid progression of normal aging, okay? It's making a sprint down the finish line, whereas normal aging is just plodding along. So a lot of times when people come to see me, the main question is, okay, so is it normal aging or is it more than that? And that's really what my job is many times. And there are ways to figure that out. When we talk about cognition, in my field, basically, there's a certain expectation I have about what someone should know and should do at every age, at a certain age. And if I see that the person can't do that, I would have to say, well, why is that person unable to perform these skills? Okay? Did they have a learning disability? Did they have dyslexia? If I rule out all the various things, and then I'm really left with, it may be a form of dementia early on. Okay? Yes, one more question. So the comment was, some people give memory loss as a diagnosis. I really don't see that as a diagnosis. I see it as a symptom. And memory loss, I have memory loss from time to time. So to me, it doesn't say anything, and it doesn't classify anything, okay? And again, for me, the question is, you have memory loss, well, how serious is it? How often does it happen? Does it happen once, or does it happen every day? And so, so I basically have to look at how serious the degree of memory loss, how frequent it is, and, how does it affect your daily life? I mean, that's really, when we talk about dementia, does it affect your everyday functioning? Okay. Okay. I'm going to move on just because, and I'll try to answer more questions later. I wanted to go into the issue of cognition because this is pretty much what I do. And I think that, I think in the field right now, I always feel that cognition is something that we need to know more about. What is cognition? How do you measure it? When we think about cognition, people start thinking about IQ tests or SATs or what have you. And, a lot of times, I think in certain fields, there's not a really good way to measure cognition. But when we talk about dementia, that's really the defining criteria. What is your level of cognition? Okay? So going back to what people think about dementia, forgetfulness is likely to indicate the onset of dementia. Okay? So that may or may not necessarily be true. Okay? Memory loss can be caused or worsened by medical interactions, medical conditions, or by depression related to life events. But you need to rule out all those causes to really make a diagnosis of dementia. Okay, so besides memory loss, which is what most people come in saying, other things to look out for is spatial disorientation. So, when your loved one comes home, do they walk down the wrong street? Do they drive to a different neighborhood? Do they get lost in Safeway or in Costco? Poor problem-solving skills. Are they neglecting to pay the bills? Are they no longer doing tax records, whereas they did before? When they write out a check, do they write it out incorrectly? Or if they write it out correctly, do they mail it? Okay, so these are all things that I hear every day. And those are the things which, for me, are more telling about dementia as it is about, memory loss per se. Okay? And impaired multitasking. So someone who says, well, now I need to focus on one thing at a time. I'm just, do not give me something else to do. I could only do A, then B, then C, then D. A lot of the tests that I give to look at like that multitasking is, I would say, start on task A, then move to task B, go back to task A, go to task C. And with people with, even in the early stages of dementia, they cannot perform these things without guidance, without prompting, without, and a lot of times people may not notice that they're having difficulty with these things. That's where that insight comes in. Okay? So memory loss is, it's bad and it may signal a dementing process, but it's not the only thing. And you want to be aware of other changes that may come up. Okay? I think another one that I remember was going to the restaurant, and someone told me, well, my husband is no longer able to decide on what to order from the menu. So decision-making, deciding what to do. Many spouses tell me about, my husband or my wife, for some reason, she's more dependent upon me. He's willing to let me make the decisions for the both of us, whereas before, that didn't happen. And the difficult part, I think, for the caregiver is, well, how much independence do I give my family member? And should I do everything or should I not do everything? So, there are a lot of issues. And, for me, I wish I could deal with many of them. But, for me, the main issue is this dementia or is this not? Okay? For people with dementia, it is easier to learn new things than it is to remember things long ago. Okay? So this is a common misconception. many people come in and tell me, well, grandfather can't have Alzheimer's because he remembers everything from his childhood. He remembers everything when, he was a little boy and when he was an adolescent. I would say, well, okay, I hear what you're saying. Does he remember what he had for breakfast? Well, he has a little bit more difficulty with that, okay? So it's not so much memory for old information. Long-term memory, when you talk about dementia, that's not the problem. Most people's long-term memory are generally preserved, okay? It's the new memory for things that just happened or things you need to do that trips the person up, okay? And so the reality is that it's the exact opposite. It is harder to learn new things than it is to remember things from long ago, okay? So, and many of the tests I have, long-term memory is not even an issue. It's just, I think it's less than 1% that people will come in and say, they're struggling with long-term memory. It's always short-term or new memory that's the problem, okay? So forgetting appointments, forgetting to eat, forgetting to dress, those are the things which, is sort of the hallmark of dementia. This is something that always gets me personally. He speaks well, he cannot be demented, okay? So many times people say, well, he's so articulate. Anybody who's articulate can't have Alzheimer's. And I think that's really deceiving when you talk about dementia. Because with many different types of dementia, language is not affected in the beginning. Okay? And somebody who has memory loss, in some ways they can hide it or they can compensate for it by talking the talk, and they can present like they really know what they're talking about. And if you didn't know any better, you can say, well, he seems just as normal as me, so what is the problem? But then when I test their memory, then it becomes a whole different ballgame. So in my line of work, language is always, to me, something that I have to get beyond, okay? And because you can perfectly have Alzheimer's, but your language can still be relatively preserved, all right? So many times cognitive disabilities can be very subtle and may not be initially displayed in the presence of other people. Language ability, as I said, can remain intact despite real deficits in other skills, okay? And the way I always do it is that I always talk to the family member, My belief is that somebody who's been married for 50 plus years probably will notice changes in their spouse. And so I'm more inclined to believe them when they say, this is not the husband or the wife that I knew. This is different. Something is going on, and I pick it up. And maybe other friends and family may not pick it up, but I see it. And so many times those may be the very, very first signs of something going on in the brain, okay? All people with dementia are incompetent. Many times people would come in after I give them the news that they have Alzheimer's, and they would say, well, do we need a conservatorship? Do we need to get a power of attorney? And the assumption a lot of times is that, well, if you have the label of dementia, you just can't do anything, correct, okay? And that is really not true. And if you, take sort of immediate action, you may really do a disservice to the family member or somebody you know. The reality is that people with dementia are not necessarily incompetent. In different stages of dementia, they may still be competent to make decisions in certain life areas. People with mild dementia can comprehend, they can appreciate information you tell them, and they can reason adequately about a choice regarding their health. Okay, so someone with Alzheimer's. Now, you may need to repeat maybe several times what you're trying to convey, but if it's in the early stages, they still may be able to understand the severity of something, and it's important for you not to discount that early on. And I think, and that touches those issues about independence and dignity, and ways to preserve that dignity with somebody. And, and even though, this is a very brief talk, I think, a lot more attention needs to be paid to, well, how do you deal with those types of issues about independence and loss of independence? And I certainly think that, for some people, it's harder to accept those changes. I mean, it's hard for everybody, but, if you've always been independent and somebody is now trying to rip these privileges from you, I mean, it's a really tough thing to grapple with. And let's talk about some mood symptoms then. So symptoms of dementia are actually symptoms of depression. Okay, and I've talked a little bit about dementia and depression, that they can, co-occur. They can go together, but they are really two separate things. They're not one and the same thing, okay? Depression can make the dementia worse, but it doesn't take the place of dementia, okay? And a lot of times when I see people, I really don't know, I have to tell you, is it the depression or the dementia that's operating? And so part of the evaluation is to tease out what is dementia, what is depression. It's not an easy question to figure out. Okay. For Alzheimer's, major depression is relatively rare, okay, although, minor depression is much more frequent, okay. My experience has been that when you talk about things like Parkinson's disease, the depression takes on a more, a stronger role. My experience with Alzheimer's is that in the beginning, depression is there. But with time, depression is not as strong as what you see with other illnesses. And I think part of that, is, the issue of insight, knowing what is going on, appreciating the changes. And so when you're less able to take a step back and recognize what's happening with yourself, I think that has some bearing on, how you're dealing with it and how you feel about yourself. But that's been my experience, that depression in Alzheimer's is less of an issue as disease progresses. And here, I know this is sort of the slide has a lot of stuff, but there are certain things that I look for in separating depression and dementia. And these are generalities. I mean, it's not like, this applies to everybody. But when you talk about Alzheimer's, people have had symptoms for a while. It's a slow process. With depression, on occasion, I mean, the disease course is shorter, Usually it may be in reaction to an event. That's why the person is depressed. People with Alzheimer's, by and large, do not have a prior psychiatric history or any history of depression. Sometimes, and people who just suffer from depression alone, they're more likely to have some form of psychiatric background, okay? So I don't know, I pretty much put up that slide just to say that there are clinical questions that I can ask that try to sort of tease out what is dementia and what is depression. It's not something that, well, you're just guessing. I mean, there's certain things that can lead you or steer you in one diagnosis as opposed to the other, okay? A lot of times, one of the things that, the one in the middle, patient complaint of deficit. Many times people who have depression, when I ask them what is wrong, they would say, oh, my memory is terrible, everything is bad. But people with Alzheimer's, they'd be less likely to say that. They'd be more likely to say, well, I don't know what my family is talking about. They see the changes, but I don't. So, there are subtle, distinct differences between these two entities. And a lot of times people with depression, when I do my evaluation, they do better than people with Alzheimer's. I mean, when you look at their memory is much, much better than somebody with Alzheimer's. And that's one of the signs that you know that you're not dealing with, a dementing kind of illness. Okay, and here, there are different tests that I give looking at cognition. And these are some of the, the things that I try to make the distinction of. Like, the first thing that says is recognition memory, So a lot of the tests I give, one of the tests I give is, I may read somebody a list of words, and I may say, what were the words on the list? And somebody with depression would say, I don't remember, I can't come up. And I'll say, well, I'll say a word. If you think it came from the list, say yes. If you don't think so, say no. Now, people with depression, when I say the word, they're usually right. They'll say, oh yeah, that was on the list. Now, people with Alzheimer's will not do that. They'll say something completely different. And that is really, in neuropsychology, that's one of the main signs that I look for with Alzheimer's, that their memory is not just not good, but it's also incorrect. So you may say one thing, but they heard something different. And so when you ask them to repeat back what you said to them, you'll get, on many occasions, a completely different version of things. And I think that's probably why there's, when couples talk about misunderstandings in their relationship. I tell him one thing, he says something else, he tells me something else. He must be doing this, deliberately. And a lot of times it's not. It's this issue of memory. You're saying one thing, but the person is processing something else completely. Okay? And again, what I mentioned at the bottom, awareness of impairment. That people with depression many times recognize that something is going on with something like Alzheimer's that may or may not be true. Okay? There's been so many occasions when I ask someone, I say, your family is bringing you in here, and can you tell me for what purpose? They're like, I don't know. They seem to think I have a problem, but I don't see it. And that's the one difference, many times with depression and dementia, that, and on many occasions they may be fighting to come in. When I see people in the clinic, there's, not many people enjoy coming to see me, okay? And I can understand that. And I try to make the experience as gentle as I can. But along with the natural anxiety that you would have, there's also this issue about insight. There are some people who just say, I really don't see what my family is telling me. And that is different than depression. That's not depression. That's something else at that point, okay? And certainly you'll have some people that say, oh, well, they may just, don't want to say it, but, there's some people which they just do not see what you're saying is going on. So the issues about recovery, okay? So common myths is that people with Alzheimer's dementia will get better. That is not true. I always feel bad saying that because I think it's kind of, I think the present, the science, the way it is, it's true. You will not get better. Medications may slow down the progression, but it doesn't stop the progression. Okay? So many people have the assumption, well, if I take Aricept, that, well, I will no longer have memory trouble. That is not the case. You may just slow the course down a little bit. Okay? How quickly a person recovers depends on how hard they work at recovering. Okay? And and sometimes family says this, that if dad or mom works harder, then they'll recover their memory. And again, when we talk about dementia and Alzheimer's per se, that is not the case. That recovery is really not the issue. It is good advice to rest and remain inactive during recovery. So having said that there's no cure, I'm not implying that you shouldn't do anything about it. A lot of times people say, well, is there something we can do? And certainly by staying physically and mentally active, that is probably the best remedy. I think the worst thing is to just sort of give up and just sort of accept that diagnosis and not do anything about it. I mean, there have been studies that said that, even into the late, the latter ages, that your brain still makes connections and you're learning new things. So I think that advice should be really taken, that physical stimulation and mental stimulation is really important, even if you have a diagnosis of Alzheimer's. So the reality of this course is that some people have dementias, which thanks to prompt diagnosis and treatment was found to be reversible. Now, this is something that I haven't mentioned in the talk, is that when we talk about dementia, there are some dementias that can be reversible and some that are irreversible. So Alzheimer's is an irreversible type of dementia. But there are some reversible dementias, and those are ones that may be related to dehydration, infections. I mentioned a urinary tract infection, taking too many medicines, taking the wrong medicines, low thyroid, that happens many times, anemia, or some problems with the blood. That there have been many studies that said that, when people experience mental changes, that it is these conditions that's causing it and not necessarily Alzheimer's. So what is the take-home message is that you really need to get a very good physical checkup to rule out all of these things, which may or may not be operating, okay? And and of course, as I said, there is no known cure for Alzheimer's at the current time. And this is something that, I'll tell you, it's something hard to talk about. Those who do not realize that there is no known cure for Alzheimer's I think a lot of times, may spend a lot of time looking for treatments that may promise certain things, but may not necessarily guarantee, recovery. And I think a lot of times, that time that you have may be really well spent in terms of making the person more comfortable, trying to have a better quality of life. So I think when I say this, is not to say the message, well, don't look for any cures, don't worry about that. That's not what I'm saying. But that, but currently there's really no, in my mind, effective treatment. And so if you have limited energy and resources, you may want to use some of that energy to, sort of having a better quality of life, whatever it is that may be. And the issue about services. Services are unavailable for people with dementia. I think this applies to different groups. I know culturally this is many times this is a commonly held belief that if you have a family member who has dementia, put that person, hide that person, don't let anybody know. And that certainly is the case. I know in a lot of Asian cultures that nobody talks about it. And of course, the most obvious, resources are the Alzheimer's Association of Northern California, and of course the geriatric health services here at Stanford. But there are services, and I think the reality is that, many people think, well, even if there is services, people don't want to be interested in it because I'll make my husband or wife feel bad if they have to seek services for dementia. And a lot of times the determining factor for use of services is really not stigma, but access, I think. And I think people just don't know where to go when they need assistance. Many times I would test somebody, I would give them a diagnosis, and they would say, well, where do we go next? Where do we turn? And that's, to me, is not a response of saying, I don't want to deal with it. It's a response of, well, can you, hook me up with somebody who knows what to do? What's the next step? And my experience has been, knowledge of available resources in the community is really what is necessary, in this case. So that's pretty much it. I'd be happy to answer any questions. Sir? Ma'am? What's the earliest age of dementia? I think generally, with dementia, there's a strong correlation. The older you are, the more likely you're going to get it. But when we talk about Alzheimer's, it generally happens after 65. But then I've seen people who have it in their 50s. My experience has been the earlier you have it, the more aggressive is the dementia. So for people who I see when they have it in their 50s, it comes on fast and it comes on strong. And so, yes. So I think there was a comment made that there have been some 3 different drugs that came out. And so would these drugs be helpful for Alzheimer's, but could it be also helpful for different types of dementia, such as non-Alzheimer's dementia, such as one you would get from a stroke, perhaps, or Parkinson's? And I think this is where diagnosis becomes very important, because there are certain drugs that will work well for Alzheimer's dementia, but there are certain drugs that will not work well for it. And if you don't know what you're dealing with, you can give a drug, the person will have a dramatic negative side effect, and you're wondering what's going on. So I think the question is, since it's so difficult for people who have Alzheimer's to accept, that there are changes, well, how do these people come in to see me in the first place, and how do they accept changes? I wish I could answer that question. I think a lot of times when I see people, they are not happy. It ranges from being sad to being anxious to being downright aggressive. I mean, I remember one gentleman, and he was a orthopedic surgeon. So you would think that, he can understand why he would need to come in. And I, silly, assumed that. And of course, he stormed out right away. And I think it was a blow to his ego to not do so well on these tests. I mean, I think it's a blow to many people's egos when, I do what I do. But it is not, I don't know how to answer that question about how do you make it easier for people to accept changes. Because I think the fundamental thing with Alzheimer's is this loss of insight. So you're trying to convince or let somebody know something about themselves, but the disease is really hitting that very thing that you're trying to get across. I mean, that's the tough part, I feel. All right. Thank you.